Welcome to The Source, where we combine the headlines with in-depth conversations with the newsmakers themselves. I'm Pinky Webb. Today on the program, government easing restrictions in the so-called NCR Plus bubble, the Modified Enhanced Community Quarantine, or MECQ, starts today. But with thousands of new daily infections and hospitals still operating beyond their limits, can we really afford to loosen health protocols? National Task Force Advisor Dr. Ted Herbosa joins us live. And a new report from the Octa Research Group shows more people in Metro Manila are dying due to COVID-19 compared to 6 months ago. The group is also pushing for one more week of ECQ. Octa Research Fellow Professor Guido David will also be with us in the program. The NCR Plus bubble transitions to a more relaxed quarantine status beginning today. Presidential spokesperson Harry Roque, who is also being treated for COVID, says Metro Manila, Bulacan, Cavite, Laguna, and Rizal will be placed under the modified enhanced community quarantine until April 30th. The provinces of Quirino and Abra and Santiago City and Isabela will also be placed under MECQ starting today until the end of April. The NCR Plus bubble had been under ECQ, the strictest form of lockdown in the last 2 weeks amid a surge in COVID-19 cases. Let's go straight to the source of the story. We have National Task Force Advisor against COVID-19 advisor, Dr. Ted Herbosa. Dr. Ted, welcome to the source and thank you so much for your time.
Thank you, Pinky, for having me back.
What were the considerations coming from the National Task Force that actually led to government's shift to MECQ?
Okay, actually, in the IATF, when they discussed this, they use actually a lot of data, a lot of evidence, which actually comes from both the health sector experts, mostly epidemiologists and infectious disease experts, and this is banged or matched against the economic experts who actually compute losses, etc. So it's a very complex decision process. But in short, I'd like to say that the decision to move towards MECQ is what I call evidence-based, or it's based on data and science from both angles. And it's a balancing act based on what the policymakers actually decide. So we will see. It is not a fixed decision. Like in any disaster or chaos, you are ready to actually move back to a stricter ECQ. Remember, modified ECQ is still an ECQ, and that's what people don't realize. It's still an ECQ. We just modify it with lesser restrictions.
Right. So you said, obviously, as we've heard in the past, every time there's a change in quarantine status, it has to really balance health and economy. What evidence was seen in the past 2 weeks in ECQ that led to a little bit more of an easing of restriction to MECQ? What was proven? What was seen?
Actually, when I looked at the data or the minutes of that particular discussions, I saw the data being presented by our losses in terms of economics, but I also saw that the health sector was already gaining in terms of what needed to be done. Like we needed to surge the hospital sector. So there were more isolation facilities that were reopened. The hospitals decided to increase their capacity for COVID-19 cases, both the moderate, severe, and also the ICU or critical care beds. So there's also the increase in ramping up of testing. So all these plans were put in place. Of course, the effects of such efforts during the ECQ, the 2 weeks of ECQ, is still going to be felt about a week later. So it's not going to be felt immediately because what you feel that only after about a couple of weeks. In fact, all our data today, like say if you look at the data yesterday, those are data of things that actually happened a week ago or 2 weeks ago because of the delay and lag of how data is reported, analyzed, and tested. You know, when you get exposed to a patient, you actually get exposed to the patient and then you wait a few days, 5 days if you're asymptomatic, get tested. If you get symptoms earlier, still a few days before you get tested, and then you get hospitalized, you get reported. So by the time that data is accumulated, there is a lag. So it's not real time as what people really think of. So there's got to be levels of interpretation.
Absolutely. It's not really real time. So what you're saying is, are you expecting the numbers to improve this week? Because we've already had 2 weeks of ECQ, and even before that, tumataas na po yung numero even before we went to ECQ. So are you hoping by this week the numbers will significantly improve?
In fact, that's what I saw from last Friday. We had a presentation from Dr. John Wong, who is our expert in the IATF that does all the projections. And we saw a slight plateauing of cases to about 12,000, 11,000 cases for their 7-day average. It's still high, but only half of that is actually in Metro Manila or the NCR Plus bubble. It's only about 6,000 new cases in the NCR for the past few days. So that's still high. That's correct, but we went down to only about 500 new cases during the previous.
But I don't understand. I hope you don't mind why you would say that the numbers plateaued to an average of 12,000.
Can
Why
you say
is
that again?
plateauing? I heard you say that the number plateaued to an average of 12,000. Why would you describe it as plateauing to 12,000?
Yeah, because if you look at the graph, it's not pointing. The weeks before or the days before, the growth was exponential. So almost every day there's a newer increase. When you say plateau, you watch several days of reports from the laboratories, and you see that the cases are not increasing. We've not gone beyond 13,000. So it's somewhere every day around 11 to 12,000. So we take that average because each day is dependent on how many labs are reporting, how many labs are functioning, if they are reported on time, etc. So there are other factors other than just new cases. So it's very important to analyze all of this. But my thinking is we're at that peak. I do hope we're at that peak, and there is evidence to actually do less restrictions and start to allow people. What is important is that not the community quarantine measures, but actually the individual minimum public health standards. We need to the people's behavior to really wear masks, to really wear the face shield, to really avoid mass gathering, and to stay at home when it's not necessary to go out.
And that's still part of the MECQ anyway. Earlier, though, you had talked about testing and hospitals. Let's first talk about testing. Do you see the testing that has been ramped up? Because health experts are saying we need to test about 90,000 at least on a daily average to be able to really find the first generation and hopefully even the second generation for contact tracing. But we're far from the 90,000 tests conducted daily.
I agree. We're far. We're somewhere around I think I saw a report yesterday of only about 36. So that's a weekend. So it's really lower. And then it ramps up during the week from Monday to Friday, goes up to about 50 to 60,000 tests a day. We're still under testing. I think what's important is when you're not testing as much, you should be targeted so that you can make sure that everybody that needs to get a test gets tested. So that's the more important one. And when you talk about testing, we're using a metric called the test positivity rate. And our test positivity rate has gone from only 5% positivity to about 20% positivity. So that's 1 in 5 persons tested get positive. So when you ramp up testing, you get more negatives, and that test positive numerically decreases. But what you want is actually the actual control of transmission, the actual break in the number of new cases. So physically, you all really want to do public health measures. The numbers are just your met, and testing can be ramped up by other things. We added the rapid antigen. So during an outbreak, one of the recommendations of the Department of Health was to use the antigen test because the RT-PCR, the real-time PCR test, is very complex and it takes too long. So although it's a confirmatory test, we can do the antigen test, and the antigen test in the case of an outbreak and in symptomatic people is very very much aligned to the results of an actual RT-PCR. So that's the one that the government purchased, and it's being distributed to local government so that they can immediately test people. The results are immediate in minutes, and they can immediately isolate those that are positive.
Are you happy with the current testing? Because you mentioned a while ago that there were some days that we reached 50,000. I know that the antigen is also supposed to be incorporated in this. We were able to speak to Secretary Vince Dizon about that. But granting that we were able to test one day 50,000, are you satisfied with that?
Oh, no, there's always room for improvement. In a public health emergency like this, you have to match what resources you have with the needs that are there. And it's very important that when the resources are less than the needs, you actually need to actually prioritize. So it's very important to use our capacity. Our capacity is not easy to increase because molecular labs are not that easy to build. You cannot build it in a day. So the way to increase it is really to do other tests as well. So there's also symptoms based wherein we get to see suspect cases so that we can already isolate them even
Okay.
before their results are there. And
Yeah,
we do
that is
this
key.
for other cases.
Yeah, that is key, no, Dr. Ted. All right, but we need to also talk about the situation in the hospitals. Have they been improving? But we need to take a very short break. The source will be right back. You're watching The Source on CNN Philippines. Our guest today, National Task Force on COVID-19 Advisor, Dr. Ted Herbosa. Dr. Ted, let's talk about the hospitals. Are you seeing any easing up or the situation getting better in the hospitals?
Definitely no. A week ago or 2 weeks ago, our hospital emergency rooms were actually swamped. Actually, the hospital isn't swamped. What is swamped are actually our emergency departments. And this is the perception of people that the hospitals cannot take in this many patients.
True.
We have enough beds. The problem is allocating these beds to the actual cases that need them. So each private hospital is only allocated about 20% of their total bed capacity for COVID-19. And a smaller percentage of that, about 10 beds for their critical care beds. And if many cases of severe or critical come and the beds are full, they're run into what we term as access block. That means patients who are supposed to be admitted can't be admitted. Now, all of this is very simple to solve by pure coordination. The hospitals, the public hospitals, have about 50% of their beds to COVID-19, and they have a lot more beds and capacity. In fact, just last week, we inaugurated several increases in the surge of beds. There's the 110-bed hospital
In Quezon Institute.
opened up at that's 110 beds with 20 beds of critical care. And there's the 960 beds opened at the National Center for Mental Health. So these are for moderate cases of COVID-19. And then we also opened 300 beds for mild and asymptomatic. This is the Manila Times College in Subic. We purposed the school for isolation. We have 165 beds in New Clark City, also for mild and asymptomatic, 200 beds in the Eva Macapagal terminal in Manila, and 100 beds in Orion, Bataan. So we've ramped up and increased the number of beds for isolation of moderate and mild and asymptomatic. What that does, it does unplugs the ER because the tendency, the human behavior is, I get a positive test, I'm going to go to the hospital. I want to be admitted to protect my family. So now we've also opened up telemedicine portals. Last night, I was in a big meeting with the Philippine General Hospital. They reopened their Bayanihan call center, 155-200, and they instituted a volunteer program called the Gabay COVID-19. And we had about 200 doctors who graduated from UPPGH who are willing to help and assist people who want to be at home.
Okay,
So
that's good to hear.
Number, find the doctor, and this will really help relieve the pressure at the emergency departments.
Then let me ask you this, just on an approximate, Dr. Ted, the ones you mentioned, I know Quezon Institute 110, National Mental, also hundreds. In total of those that you mentioned, how many would that be, just approximately?
For the critical care beds, after discussing all of those, that's a total of 164 additional critical care beds, an additional 2,227 regular beds for moderate and severe, and additional 765 beds for the mild and asymptomatic. So it's
Okay.
a total of 3,156 beds for the NCR Plus. That's 3,000 additional that we ramped up. So we're not hearing any more stories of people having, dying in the emergency department or dying in a car or ambulance. So
Yeah.
they're good. That's good. That's good. And we do hope that this surge will continue to support the people who are getting positive.
Frankly, the numbers are good because if you're telling us that there will be 3,000 beds opening up, let's be clear about this. Opening up or have opened?
Have opened. These are the beds that have opened last week. So these are the things we did for an ECQ. That's why you implement an ECQ to give you time to catch up with the number of cases. So the government has ramped up the cases. Even the seats in there were complaints of the One Hospital Command, which is our call center and our dispatch and trafficking for patients. They've increased also the numbers of seats that will actually be able to answer your call, so you don't get a busy number, or now you have other numbers to call. For example, if you're in the private sector, most of the private hospitals have set up a home care program so that you can dial a number, and the private hospitals, Medical City, Cardinal, and St. Luke's, all have what we call home care program for COVID-19, or for the mild. Just last Saturday, we had a very big conference held by Dr. Ana Ong Lim, one of the experts in the technical advisory group.
Yes.
And several advice to about 30,000 viewers of that webinar.
Yeah. The one in Santuario, I believe. That's why I've always also wanted to get her to be able to help the public, because people really need to know what to do, what to expect, what to have at home and all that. But I need to bring this in, Dr. Ted. And this needs to be told. I was talking to a ER doctor last night, and it's not to him telling me puno pa rin dun sa private hospital that he works in. In fact, he was in the triage area, and he had to choose which one among the patients he had would have been the severe, because hindi na po kaya nung private hospital na ipasok pa sa ER. So that's a personal experience from a doctor who even said it's so traumatic to even have to choose kung sino lang ang pwede dahil wala nang kwarto sa ER, wala nang space rather sa ER. So can you try to connect this for us, please? If there are 3,000 beds available today, bakit po nangyari pa rin to? Kausap ko lang po siya kahapon.
Thank you very much. No, I train. I'm an emergency medicine doctor, and I trained many emergency medicine. You probably are talking to someone I also probably trained. And triage is an activity that we do every day in an emergency department. We always do single patient triage, but today we have what is called a deluge of new cases, wherein you have to make choices. And this is part of the science of emergency medicine, is being able to prioritize the severity of illness. And many people think that if they do come to the ER, they will immediately be admitted. That's not true. Even prior to the emergency situation, we actually choose based on your what we call emergency severity level. So if you're a good emergency physician, you should be able to make sure that nobody dies on your watch. And I empathize with this ER doctor. He's probably burning out because of the number of cases, and he should probably take a rest and should be relieved by other doctors who are fresher, because your intellect and you become clouded when you are tired, when there's too much work. So very important also is to support our people that work in the ER with relievers. And that's part of what the government did. We got doctors and nurses from Cebu who volunteered to come here. I think there were about 50 of them. I saw them in the news, and they volunteered the same way we volunteered when Cebu was in trouble last year. In July last year, we sent about 50 doctors, because at that time, the doctors were also burning out in the ER. So the experiences of your friend, emergency doctor, is correct. It is real. And it is what happens on a day-to-day basis in an emergency department.
Okay.
So we make, and that's what he's trained to do. He's trained to make those as an emergency doctor.
And I think all the other doctors, all the ER doctors as well in the triage system or even in the ER experience the same thing. But don't just hear it from the doctor I spoke to. There's so much also on social media na hanggang ngayon nahihirapan pa rin po sila maghanap ng ospital. I hope to see very soon that we don't see stories about that anymore. Anyway, Dr. Ted, unfortunately we've run out of time. I still have Okta after you. So thank you so much for your time, Dr. Ted Herbosa. And we'll be taking a short break. We will be talking to Okta Research Fellow Guido David after the break. We'll be right back.